Hello everyone, my name is Shalom. I'll be starting off for Team 2 with my Pico question. For a client with high caries risk, is dental fluoride application enough compared to at-home fluoride practices to prevent caries formation? This is my treatment plan having caries as deficit for the client. DHD would be biological sound or functioning dentition. Etiology would be Streptococcus mutans. Evidence is as seen on x-rays and diagnosed by dentist. The DHI is to provide client referral for dental restoration by appointment number 4, explain to client how caries develop, and prevention of it by appointment number 4. CCG is ask the client to book an appointment to see dentist for restoration by appointment number 6, and client to understand the benefit of fluoride to prevent caries by appointment number 4. The first articles, we've got participants of 68,757 veterans. They are primarily male and Caucasian, ages between 40 to 58. The purpose of this study is to evaluate effectiveness of topical fluoride application and preventing demineralization. Information were obtained from the U.S. Department of Veterans Affairs Medical, Dental, and Pharmacy databases from October 1st, 2008 to June 30th, 2018. The inclusions of the study, they should have high caries risk, having 2 or more caries-related restoration within 1 year period, should be able to come in for 3 years continuously for a follow-up, eligible for comprehensive and continuing dental care. For the veterans who attended the study, they completed dental prophylaxis, including fluoride varnish, gel or rinse application for twice a year. The specific adjusted ratios were taken. This is the odds of generalization between the fluoride application. For veterans who received gel or rinse treatments, they were 28% less likely to need further caries-related treatments. And for varnish fluoride users, they have about 29% less likely. The results for this article is that the veterans who received fluoride treatment had almost 29% fewer odds of requiring caries-related treatment during the observation period than those who did not. Conclusion for the first article is that for high-risk veterans, topical fluoride treatment, whether it's varnish, gel, rinse, it significantly reduces the chance of future caries-related treatments. It must have multiple application for it to be beneficial than just being a single application. For article number 2, we have participants of adult patients with untreated root caries. The purpose of this one is just to compare with fluoride varnish application and to assess which one is more effective preventing caries in adults. This is a randomized controlled act, so we've got participants of test group and control group. Methods for this one is that the adult patients were divided into 2 groups. We've got the control group and the test group. The control group used regular fluoride toothpaste, which had 1,350 parts per million of fluoride, and the test group used a high fluoride toothpaste, had the 5,000 parts per million fluoride. They were both groups were given identical toothbrush and toothpaste packets to use twice a day and had to come in every 3 months for redistribution of the packets. The intervention was measured at baseline, so that's the initial distribution of the packets, after 3 months and 6 months. Results of this one, surface hardness were measured at baseline. There's no significant finding between the 2 groups. The hardness surface significantly improved between all time points in the test group from baseline. After just 3 months, it's about 0.08. From 3 months to 6 months, there is a 0.01 prevalence to caries. The control group, the hardness surface in the control group only improved only after 3 months. So from baseline to 3 months, there's still 3.58% of prevalence of caries. From 3 months to 6 months of usage of regular fluoride toothpaste, there is a 1.22 prevalence. Conclusion for this article is that high fluoride toothpaste work well to lower the prevalence of fluoride toothpaste need dedication and regular use for it to be effective, while having fluoride varnish, the advantage of this one is being low maintenance. Was my Pico question answered? Yes. Article number 1, it stated that fluoride varnish application for twice a year have demonstrated to improve enamel and prevent cavities, hence it reduces the incidence of caries in adults. Article number 2 stated incipient caries can be effectively treated with fluoride toothpaste, but for best results, it must be used twice daily and have a minimum concentration of 5,000 parts per million of fluoride. It is enough to use fluoride varnish twice a year to keep cavities from developing. It is upon to clients' decision whether they want to go ahead with having varnish applied twice a year or using it at home. That concludes the end of my discussion. Thank you.
Hello everyone, my name is Daisy and I will be discussing Pico question number 2. For a client with missing teeth who is interested in removable partial dentures, will fixed partial dentures be better in providing optimal oral function? Oral functions can include mastication, respiration, and speech. I will discuss two studies that focuses on masticatory performance since we will be discussing about dentures. Here is a treatment plan starting from dental hygiene diagnosis to client-centered goal. As you can see, our client has missing teeth due to periodontal status. The first article was written by Tosuku Yoshimoto and company. They investigated the effects of denture design, especially the use of indirect retainers and major connectors, on masticatory function in patients with mandibular bilateral distal extension dentures. This randomized controlled trial was published in the Journal of Prosthodontic Research on February 4, 2023. The participants in this study visited the Niigata University Medical and Dental Hospital in Japan between October 2015 and July 2020. There were 53 participants, 29 men and 24 women. The inclusion criteria were as follows: has missing teeth number 6 and 7 on both sides of the mandible, Kennedy classification class 1, Eichner classification group B2 and B3, did not complain any pain or functional disturbances, with denture abutment teeth in good periodontal condition, with no known history of TMD, and those who were able to understand and appropriately respond to a questionnaire. The masticatory performance was evaluated by the MP scoring method, using a piece of test gummy jelly developed by Nakubi and Company. The participants were instructed to chew on a piece of test gummy jelly 30 times and subsequently expectorate the masticated fragments onto a piece of gauze spread over a paper cup. MP was evaluated by visual scoring using a 10-stage scale based on the crush status of the gummy jelly. MP was then further divided into two groups: good chewers and poor chewers. As a result, MP was positively correlated with the number of functional teeth, occlusal support, and number of rests. Logistic regression analysis revealed that the number of functional teeth and the presence or absence of an indirect retainer were factors that significantly influenced the masticatory performance. It was then revealed in this study that the MP of patients with H-nerve B mandibular bilateral distal extension dentures were affected by the presence of an indirect retainer. The results suggest that even when only a few functional teeth remain, good mastication or masticatory function can be maintained by designing dentures with the appropriate placement of an indirect retainer. That is for Article 1, the intervention, removable partial dentures. We will now move on to the second article for comparison, which is also a randomized controlled trial that focused on masticatory performance and masticatory efficiency of fixed partial dentures. This article was written by Yogesh Kumar and Company and was published in the Journal of Prosthodontics on November 20, 2015. The purpose of this study is to determine whether an FPD or an implant replacement of a single missing tooth leads to better masticatory efficiency and patient satisfaction. 120 participants with missing mandibular right first molars were selected on the basis of predefined inclusion and exclusion criteria. After obtaining informed consent, 60 participants were randomized to the teeth supported group and 60 to the implant placement group. The study duration was 16 months. Patients in both groups were made to chew on the right side. Mean values for questions about masticatory performance and efficiency were calculated. Data compiled from both arms of the study were evaluated for intergroup differences and analyzed statistically using a statistical package for social sciences or SPSS for mean standard deviation, Z-test for questionnaire values, and student T-scores for efficiency and performance. The results of this study suggested that although masticatory performance and efficiency were not statistically different for single teeth replaced with implants or FPDs, patients perceive higher satisfaction with implant restorations. They also preferred the shorter treatment times for rehabilitation in the FPD group. I am now going to answer the most important question in my presentation. Did it answer my PICO question? And my answer is no, because both studies suggested that optimal oral function, specifically masticatory performance and efficiency, is achievable in both removable and fixed partial dentures. That concluded my research. These are my references, and thank you all for listening.
Hello everyone, my name is Chrissy and I'll be starting with my PICO question number 3. For patients with oral candidiasis, will the use of nystatin oral suspension compared to clotrimazole lozenges resolve oral candidiasis symptoms more effectively? And here's the part of the treatment plan. DHD, skin and mucous membrane of head and neck, etiology, overwearing denture, evidence, white spots inside the oral cavity, as well as pain during swallowing. DHI will educate the client on how to clean the denture that can help maintain a healthy oral cavity by appointment number 5. And the CCG, client will recognize the cause and preventions of oral candidiasis due to overwearing of denture by appointment number 5. So the first article that I would discuss is the efficacy of nystatin for the treatment of oral candidiasis. So search engine is PubMed Central National Library of Medicine, published 2016 of March. Study design is randomized controlled trial, and this study examines were conducted on various patients groups, 3 individuals with denture stomatitis, 3 on infants and children, 3 on HIV patients, 1 on cancer patients with other mixed group, including patient with xerostomia and immunocompressions from organ transplantation and denture wearers. So the inclusion criteria, the review included randomized controlled trials comparing nystatin with other antifungal treatments or a placebo for oral candidiasis. There were no restrictions on age, sex, or race. The primary outcome was clinical cure, defined by the resolutions of oral lesions and symptoms, while the secondary outcome was mycological cure, determined by negative smear or culture results. And for this article number 1 results, the meta-analysis found that nystatin pastilles were significantly more effective than a placebo in treating denture stomatitis. Descriptive analysis indicated that combining nystatin suspension and pastilles for 2 weeks resulted in higher clinical and mycological cure rates. And 4-week treatment with pastilles showed better clinical outcomes than 2 weeks. So, for the conclusion of article number 1, nystatin pastille was significantly superior to placebo in treating denture stomatitis, while nystatin suspension was not superior to fluconazole in treating oral candidiasis in infants, children, or HIV/AIDS patients. So indirect evidence from a descriptive study demonstrated that administration of nystatin pastille alone or pastille and suspension in combination is more effective than that of suspensions alone. Prolonged treatment durations for up to 4 weeks can increase the efficacy of nystatin. Now that we've discussed the findings from article number 1, let's move on to the next article, which further builds on efficacy of clotrimazole for the management of oral candidiasis. So, search engine is PubMed Central National Library of Medicine. Study designs is a randomized controlled trial, and for the participants included 1,685 patients with an average age of 26 to 50. 14 studies used to clotrimazole thrush formation. So for article number 2 methods, this research aimed to assess the comparative efficacy of clotrimazole and other antifungal agents in treating oral candidiasis by analyzing randomized controlled trials. So the primary outcomes of interest were clinical response, mycological cure rates, relapse rate, incidence of systemic infections, and compliance. Additionally, the evaluations of adverse effects was important to determine the safety profile of clotrimazole compared to other antifungal agents. This comprehensive approach aimed to provide insights in both the effectiveness and the safety of clotrimazole in treating oral candidiasis. And for the results, the findings revealed no significant difference in clinical response between clotrimazole and other antifungal agents. A sensitivity analysis comparing clotrimazole to other topical antifungal showed no difference in clinical response, mycological cure, or relapse rates. And for the conclusion of article number 2, this meta-analysis found that the clotrimazole is effective as another topical treatments for treating oral candidiasis. So did Pico question answered? The answer is yes. This meta-analysis found that the clotrimazole is as effective as other topical treatments for mild to moderate oral thrush, offering localized antifungal action with minimal risk of systemic side effects. Both nystatin and clotrimazole are effective options, but the choice between them may depend on the patient's preferences and the severity of the infection. And that would be it for my topic. Thank you.
Hi everyone, I'm Claudia, and today I'll be going over Pico number 4 for a client with severe stage 4 periodontitis. Will non-surgical therapy compared to surgical therapy help treat periodontitis better? Here is part of the treatment plan. DHD is skin and mucous membrane integrity of the head and neck, with the etiology being insufficient plaque biofilm removal, and evidence of stage 4 grade B periodontitis, plaque index of 0.52, bleeding index of 9.45, generalized mild horizontal bone loss, as well as localized vertical bone loss. The client also presents with probing depth from 4 to 5 millimeters, and we have evidence of generalized scanty subgingival calculus and localized moderate subgingival calculus on molar region. Our first DHI includes educating the client on the importance of proper biofilm removal in order to minimize disease progression to adjacent tissues. And the client's CCG includes verbalizing the importance of proper biofilm removal in order to minimize disease progression to adjacent tissues by appointment number 4. The second dental hygiene intervention will be providing client with oral self-care instructions on how to properly remove the biofilm before it accumulates and become hard deposits. And the client will show how to properly remove the biofilm from the teeth. He will also be performing the Stillman's toothbrush method and how to use proxy brushes, all by appointment 4. And lastly, will provide the client with multiple sessions and a thorough non-surgical periodontal treatment to remove calculus from those 5 millimeter pockets in office. And CCG 3 for the client will be to consent to manual and ultrasonic debridement by appointment number 4. So article number 1 was a randomized controlled trial that included individuals aged 25 to 70 diagnosed with periodontitis stage 3 or 4, grades A to C. And the main purpose was to provide evidence on the clinical effectiveness and applicability of a modified minimally invasive non-surgical therapy compared to surgical therapy. There were 2 groups. The modified protocol was done under local anesthesia with no adrenaline and root debridement using piezoelectric devices with thin tips, whereas the control group was performed with the scaling and root planing with ultrasonic tips and curettes under local anesthesia. And there was also a preferred approach for residual pocket depth of more than 5 millimeters. There was a buccal flap elevation with simplified incisions done. The conclusion of this article is that minimally invasive periodontal therapy is not inferior to surgical periodontal therapy. However, because studies is still ongoing in terms of finding superiority, it did not answer my PICO question, which led me to article number 2, which consisted of a systematic review and observational study, and participants included 1,182 individuals with adult periodontitis. The main purpose was to assess the effectiveness of active non-surgical periodontal therapy in individuals with adult periodontitis. Methods. So the initial assessment, at the initial assessment, there was a full mouth sharding done with radiographs and recording of the probing depth as well as the bleeding. The treatment consisted of 2 to 5 sessions of scaling and root planing, and local anesthesia was optional for the clients, and it was done using ultrasonic and hand instruments. Now, there were 2 follow ups done, one at 6 weeks and the second one at 2.5 months. The overall results included 39% of patients being satisfied with treatment, but it was more tooth specific. As an example, for a front tooth, 85% success rate was the result, whereas for a molar tooth, 47% success rate. There was also an improvement on bleeding upon probing, and something important to highlight is that for those clients that smoke during treatment, they had about 71% failure rate. So, did it answer my PICO question? Yes, it did. Mostly because the study demonstrated that active non-surgical periodontal therapy for adult periodontitis is successful, especially for those areas that present with 5 mm pockets or less, or if you are treating front teeth as well as premolars. However, surgical periodontal therapy remains the treatment of choice for pockets of more than 5 mm, as well as for molar teeth. So even though more invasive, the client will get a better result. Thank you.
This is Pico number 5 presented by Zena. For a client with severe periodontitis, will platelet-rich plasma bone grafting be more effective than using synthetic graft material in restoring bone loss? The treatment plan for this client is due to plaque index of 0.52 and bleeding index of 9.45 with general probing that ranges 4 to 5 millimeters. This client will clearly explain the difference between gingivitis and periodontitis by the end of the treatment. In the first article, we read PRP for periodontal regeneration in the treatment of intrabony defects. It is published by Oral Surge on July 2015, and the study design is meta-analysis on prospective clinical trial with 10 participants, and the purpose of this study is to assess influence of PRP on regeneration of periodontal intrabony defect by means of evaluating clinical and radiographic outcomes in prospective human clinical trials. In the methods here, an electronic literature search was conducted by 2 reviewers in several databases up to February 2014, reporting that radiographic and clinical outcomes PRP for regeneration intrabony periodontal defects. Random effects meta-analysis of the selected studies were applied to avoid any bias being caused by methodologic differences among studies. The results are there is a specific outcome, which it should be p-value equals to 0.09 millimeter, and the p-value that is less than 0.05 typically indicates statistical significance. Therefore, in bone level, the result was 0.007. In attachment level, it's 0.0008, and marginal gingival level is 0.03. In conclusion, the results indicate that the changes in bone level and attachment level are significant, while changes in marginal gingival level and other measured outcomes may need further explanation due to smaller effects or statistical insignificance. In the second article, we compare PRP and synthetic graft for bone regeneration after third molar extraction. It is published by Anne Maxilloface Surge on December 2015. The study design is randomized controlled trial with 10 participants, and the purpose is to compare efficacy of platelet-rich plasma and synthetic graft material for bone regeneration. The methods were following extraction. PRP was placed in one extraction socket and synthetic graft in form granules in another extraction socket. Patients were assessed for postoperative pain and soft tissue healing. Radiological assessment of the extraction site was done at 8, 12, 16 weeks interval to compare change in bone density in both sockets. The results were there was pain there was less pain on PRP side when compared to synthetic side. Soft tissue evaluation done using gingival healing index given by Landry et al. Showed better healing on PRP side when compared to synthetic side. Radiological assessment showed the gray level values calculated at 4 months at the PRP site were comparatively higher than the synthetic site. In conclusion, this study showed that the PRP is a better graft material than synthetic graft in terms of soft tissue and bone healing. However, more elaborate study with a large number of clinical cases is very much essential to be more conclusive regarding the efficacy of both materials. And the question was answered yes. The first article stated that using PRP had significant changes in bone level and attachment level and can offer some beneficial effects on clinical and radiographic outcomes for regeneration of periodontal intrabony defects. In the second article, it stated that PRP is more suitable for patient comfort, better soft tissue healing compared to synthetic material and bioactive glass. Although both studies also stated that PRP and other bone graft materials are ongoing research due to various research thus makes it difficult to narrow clear conclusions.
For my question, I chose, for a client with periodontitis, will tobacco with nicotine, as compared to vaping with nicotine, cause an increased risk factor for the client's periodontal condition? Here are some deficits identified for Miss Sophia. First, my article was periodontal health status in adults exposed to tobacco heating system aerosols and cigarette smoke versus non-smokers. There were 3 groups of participants. Over half were female. This included those with good health, 20 teeth, smoking at least 3 years, daily consumption of 5 cigarettes or heat sticks. It excluded those with antibiotics or chlorhexidine use, and those under previous periodontal therapy. I chose this article because it closely aligned with my Pico question, focusing on tobacco heating systems, which are similar to e-cigarettes, the difference being that instead of heating a liquid with nicotine, this system heats tobacco leaves but does not burn them. Since this was a cross-sectional study, it was able to show the correlation of a single point in time, but it was unable to show cause and effect. This study used various statistical tests that represented the calculation of different values. The table here represents the categorical data showing a comparison of the sociodemographic variables among the groups. Quantitative data was also collected in the form of probing depths and cal, which is shown on the next page. The results of this study were that cigarette smokers had the highest evidence for periodontal health issues with an odds ratio of 4.7. One thing I found notable was that the plaque accumulation and gingivitis data appeared to be the lowest in the tobacco heating system users compared to the other groups. This article did find that tobacco heating systems are less harmful to periodontal health than conventional cigarettes, but still pose a risk. I feel this article is credible and valid because it included scientific background, appropriate statistical methods, all while acknowledging the study's limitations, which are right here. The next article was comparative effects of e-cigarette smoking on periodontal status, salivary pH, and cotinine levels. Something I found really interesting about this one was all 144 participants were male, and that was deliberate because the researchers wanted to eliminate the hormone fluctuations such as estrogen and progesterone since they have been associated with periodontitis. I selected this article because, again, it aligned with my question. This time the comparison was made with e-cigarettes. Particular attention was paid to the impact that e-liquid can have by altering the pH of saliva and elevating cotinine levels. And cotinine is a biomarker in saliva that metabolizes nicotine. This study was a cross-sectional study where the examiner was blinded to the groups, and just like the first article, it can't prove cause and effect. The categorical data shown in this table includes smoking status and daily nicotine consumption, while the quantitative data included the plaque index, gingival inflammation, pocket depth, and cal, shown on the next page right there. The results found higher scores for pocket depth over 4 millimeters and cal in cigarette smokers. However, e-cigarette smokers had higher readings for gingival inflammation compared to cigarette smokers, likely due to the constriction of blood vessels that we know smoking causes. As expected, it also showed that e-cigarette and cigarette smokers had higher levels of cotinine than non-smokers, and they had more acidic saliva. So here you can see the two graphs. The top one represents the cotinine levels, showing that they're almost identical between the two types of smokers, since both contain nicotine. The graph below is for the salivary pH, and it depicts the significant drop in the pH in cigarette smokers. So it can be stated that a client with periodontitis using e-cigarettes may have a lower risk compared to conventional cigarette smokers, but the risk is still higher when compared to not smoking at all. This conclusion is supported by the quantitative data, and it is credible, as it used appropriate methods while acknowledging the study's limitations. Clinically, these articles show that e-cigarette and tobacco heating system users have better periodontal health than cigarette smokers. Statistically significant differences are observed in probing depths and cal. So yes, my question has been answered with no conflicts. This information would be helpful to dental practitioners when advising patients on the products and relative risks during a tobacco cessation process. And the findings would support an immediate switch to vaping, with the future goal being quitting altogether. Thank you.
Hi everyone, my name is Lisandra, and today I'll be doing Pico question number 7. For a client with temporomandibular disorder, will Botox therapy compared to arthrocentesis lead to an improvement in TMD symptom management? Here's a portion of my treatment plan: DHD, freedom from health risk; etiology, TMJ pain; DHI, refer client to DDS and inform them how untreated TMJ problems can worsen over time, potentially leading to an increased pain, limited range of motion, or further joint damage. CCG, client will book a consultation with a general dentist to assess bilateral deviation and crashes and explore possible treatment options, such as Botox injections for muscle relaxation or arthrocentesis for joint lavage by re-eval appointment. Here is article number 1. It was a clinical study conducted in October of 2016. And before I start, I want to explain the differences between Botox therapy and arthrocentesis. Botox is an injection that you get into your muscle and it helps you with bruxism. And arthrocentesis is a joint cleaning or a joint flushing where they remove substances from your TMJ. It helps you to reduce inflammation and stiffness. So Botox is a muscle-related procedure, and arthrocentesis is a joint-related procedure. Back to article number 1. They had 20 patients with TMD divided into two groups. Group A, 12 patients treated with arthrocentesis and Botox injections. Group B, 8 patients treated with just Botox. The purpose was to check the effectiveness of arthrocentesis and Botox, focusing on joint pain reduction and masticatory muscle tension. The methods used were the visual analog scale for pain measurement and the maximum interstitial opening for joint mobility. Results: Group A, which had both treatments done, arthrocentesis and Botox, had significant improvement in pain and significant improvement in joint mobility. Group B, which only had Botox, they also had an improvement in pain and mobility, but a lot less than Group A. Conclusion: the study indicates that combining arthrocentesis with Botox therapy offers better clinical outcomes for TMD symptoms than Botox alone. The combined approach appears to address both muscular and joint components of TMD more effectively. Did it answer my PICO question? Yes. The study shows that combining Botox therapy with arthrocentesis results in a better symptom management for TMD. While Botox alone helped reduce pain and improve joint mobility, the combination therapy led to more significant improvements, suggesting that targeting both muscle tension and joint inflammation is more effective than using Botox alone. Article number 2 was recently conducted in September of 2024, and it was a meta-analysis. They had 1,904 patients with TMD, and the purpose was to check the efficacy of different arthrocentesis therapies, like hyaluronic acid, platelet-rich plasma, injectable platelet-rich fibrin, and bone marrow aspirate concentrate for TMD symptom management. Results: all of the therapies were identified to be very effective for TMD symptoms, with significant pain reduction and an improvement in TMJ function. Conclusion: while Botox therapy was not included in the clinical study, the results highlight that all of these therapies are optimal for management TMD symptoms. Did it answer my PICO question? No, not directly. This article provides sufficient evidence that arthrocentesis is a superior therapy. However, it does not directly compare arthrocentesis with Botox. Nonetheless, the findings suggest that arthrocentesis is the preferred treatment for TMD. And that's the end of our presentation. Do you guys have any questions?